Welcome to this GSA Momentum Discussion webinar titled Integrated Obesity Care for Older Adults, Turning Vision into Practice in the United States. This session builds on our prior conversation about the European Association for the Study of Obesity position paper on obesity in older adults and turns to how coverage, research, and community practice in the U.S. are evolving to put that vision into action. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA, and I'm pleased to serve as the moderator and to introduce our panel for today. Dr. John A. Batsis is an associate professor at the University of North Carolina School of Medicine at Chapel Hill in geriatric medicine and the Gilling School of Public Health and Nutrition. Dr. Batsis's work centers on the relationship between obesity and sarcopenia in older adults, on multi-component diet and exercise interventions to improve physical function, and on the use of technology such as telemedicine and remote monitoring to support healthy aging. Joining Dr. Batsis is Christy Gallagher, who coordinates the Obesity Care Advocacy Network, or OCAN, of which GSA is a member. And she also serves as the Associate Director of Research and Policy for the Stop Obesity Alliance at the George Washington University's Milken Institute School of Public Health. Christy has spent more than 2 decades working on health policy in Washington, D.C., and through OCAN and STOP, she works at the intersection of research, policy, and advocacy to expand access to evidence-based obesity care. We're also joined by Dr. Katie Porter Starr, Associate Professor of Medicine and Geriatrics at the Duke University School of Medicine, and Research Health Scientist at the Durham VA Health System, where she co-directs the Duke Center for Aging Clinical Nutrition Laboratory. Her NIA and VA-funded research focuses on understudied older adult populations at high risk for chronic disease and functional decline. And finally, it's my pleasure to introduce Paige Dennison, Director of Health, Wellness, and Project Enhance at Sound Generations in Seattle. Paige has more than 20 years of experience with evidence-based health promotion, programs for older adults, and adults aging with disabilities. She oversees the national licensing, training, and research coordination of Enhanced Fitness and Enhanced Wellness, programs that reach tens of thousands of older adults annually. And before I turn to Dr. Batsis with our first discussion question, I'd like to just mention that you're welcome to put your questions in chat and any comments that you have in chat, and we will take questions at the end of the discussion. And actually, Crystal's putting that right there in the chat right now. She's saying type them into the QA feature on Zoom, so not into the chat, but into QA. And so let's start, Dr. Batsis, with you. To open, how would you frame the shift from recognizing obesity in older adults as a chronic disease to building an integrated, person-centered model of care in the U.S.?
Well, thank you, Jen, and to GSA for the opportunity to be here today, first and foremost. And it's always a pleasure to work with colleagues on this call and colleagues at GSA. So, as many of us know, obesity is a major public health concern, and we'll be touching upon that during today's webinar. The American Medical Association and other professional societies have really categorized obesity as being a chronic disease, very much like hypertension, high blood pressure, diabetes, high cholesterol, and the like. And we need to be thinking about it that way. However, the challenges that we've had in clinical practice has been really how do we engage our older adults in particular and our healthcare providers and our community-based systems to really focus on the patient. And we'll be talking a little bit about biases later as well, but thinking about how do we eliminate or minimize the weight stigma and able to minimize the ageism in our healthcare system. So we have 2 biases that are really compounded to itself. We really need to focus on the person. What's important to the person? We need to really thinking about moving away from really the numerical value of, well, how much weight do I lose, to more what's important to the patient. Is it I want to get on I want to be able to play with my grandchildren or be able to walk around the block or be able to do given activities. It's really a function-based approach. And I think that's really much more important as we kind of go, as we transition into our older adult years.
Great, thank you. And you mentioned patient-driven goals of care, certainly one of the most important tenets of integrated obesity care for older adults. But what are some others?
So I think patient, their families, and thinking about some of their other chronic diseases, quality of life, extremely important. Maintenance of independence, extremely important, to all older adults want to not only live longer. That's less of an issue. They want to compress that morbidity and the consequences of that morbidity. And I think that is something that we really, as I care for older adults in my clinical practice, I see that over and over. It's not necessarily about living longer, it's living better. And we know, unfortunately, obesity being a chronic disease affects many multiple systems, and that can impair one's physical function and quality of life. So really using those as kind of our endpoints and then working our way backwards and figuring out what is important to the patient.
Great, thank you. And Dr. Starr, I'll turn to you now. You've been involved with the GSA KAER Toolkit for the Management of Obesity in Older Adults since the beginning, as has Dr. Batsis. So how does that tool help clinicians and care teams turn those principles that Dr. Batsis just spoke about into routine practice for older adults? Ooh, it looks like Dr. Starr might be frozen. We lost her. Let's see. She's coming back. There she is. Hi, Dr. Starr. You're on mute. Welcome back.
So sorry. I have no
That's
idea what
okay.
happens.
That's
Well,
fine.
first, I am so thankful to be here. And I also feel like I won the lottery because I get to talk about the CARE framework. So, what I love about the CARE framework is really that it takes something that can feel very abstract when we talk about this person-centered obesity care, and it turns it into really 4 concrete, doable steps that we can actually fit into our busy clinic day. Dr. Batsis, John, really dove into some of those things. And it is important for us to have these practical approaches. So those steps are first, kickstart the conversation. Second is going to be to assess. Third is to evaluate. And then the fourth is to refer. So instead of really leaving every clinician to figure out really what does that person-centered approach look like, this really gives us and the whole care team a playbook that we can use, so that we have a very evidence-based approach to thinking about obesity care for our older adults. So first, I really like the fact that it moves us past the scale and really past BMI. We know that BMI is important, but it is a rough screening tool. And I think it's really important that we understand that it's going to vary a lot from person to person. It changes with age, sex, race. So it only really loosely tells us how much body fat someone can actually be carrying. So what the toolkit does instead is it points us towards this fuller picture, right? Really a medical, a psychosocial assessment and decisions made together with that patient. And honestly, that's exactly what our older adults with our multiple comorbidities need. Secondly, it starts taking the conversation and starts making the conversation feel normal. I think that there is a lot of avoidance of bringing up weight with our patients. And when it doesn't come up, our patients oftentimes, or when it does come up, our patient oftentimes can feel very much judged. What we know from the research is that people are actually much more likely to lose weight after having this respectful, non-judgmental conversation. So that first kickstart step is really not just a nicety of, hey, let's enter into this conversation. It's really an evidence-based practice that has evidence that really supports the ability to have someone actually change their weight loss journey, change their weight loss trajectory. The third thing about our CARE toolkit is it really spells out the kind of assessments older adults really need. So again, not just weight, but again, like Dr. Batsis was talking about, we're talking and thinking about the functionality, our mobility, bone health, joint health, nutrition. It really gives us this look at medications and the environment, those social situations. All of these play a role in a person's ability to not only start a weight loss journey, but really to be able to maintain. We know that nearly 40% of patients with obesity are taking medications for other conditions that actually promote weight gain. So really being able to think about all of those parameters are really important. We also know that food insecurity is something that is, not uncommon, particularly in our older adult population who are on a fixed income. And so even being able to think about that and have that conversation, I think there's also the misconception that if somebody is food insecure, then they're not going to have obesity. And we know that's absolutely not the case. The last step that I really want to emphasize here is that refer step. I think this is oftentimes where we miss the mark as providers. We may be doing a great job at the other three, but we're not thinking about how to actually connect people to our community-based organizations, our evidence-based programs, to dietitians, to physical therapists, to exercise physiologists, to pharmacists. Really being able to communicate those exercise programs that are out there. And that is so important because, again, we're building up this conversation, but we have to be able to refer them and give them those next steps. So, really that CARE framework gives teams that structure so that we can really deliver this care not only over time, but also using this evidence-based approach.
Great, thank you. Well, you talked a little bit about starting those respectful conversations. So what does it look like to start those conversations? How do we avoid weight bias and really center those conversations around health and function and individual goals?
Yes, absolutely. When we think about weight stigma, it's not just uncomfortable for the patient. We know that is actually harmful to their health. We have evidence that actually supports that. When people experience weight bias, there has been evidence that shows that we see worse outcomes. We know that they feel judged. They're going to listen less. They're going to come back less. They're actually going to engage in less care. However, if we can really flip that around and think about respectful, non-judgment conversations, the evidence shows us that people are actually more likely to succeed at losing weight and actually being able to maintain that weight. So that kickstart that conversation really is supported by that evidence, and really getting that conversation in the right manner so that we can really start talking about our treatment options and having that conversation with the patient and what matters most to them. So how do we really do that? It can be very tricky. It can feel very uncomfortable. There's some things that I think have helped me as a provider and what our evidence actually shows us. The first one is really asking permission and ask about the language in which the person wants to use. So there's no single word that works best for everyone. And we know that most hurtful words are things like morbid obesity, fat, and even using the word obese. Instead of using it as a person first language. What we really want to be saying is a person with obesity. Obesity is a disease. And so when we can use that form of language, and when we really think about obesity as a disease, it's a small shift, but it really keeps the condition from becoming that whole person identity for the patient. Some of the other things that we can use are words like weight, unhealthy weight, high BMI. These can sometimes tend to land more motivating. But again, I think that person first language is where we really want to start practicing. We also want to make sure that we're not equating weight with willpower. We know that obesity comes, it's multifactorial. We know it's biology, it's genetics, it's life circumstances, it's environment. And on top of that, we also know that when someone loses weight, their body actually fights to get that weight back, or we know that we see an increase in hunger, we see an increase in a reduction in our metabolism. Our metabolism starts to slow down. So again, really understanding that when we make the assumption that a person just isn't trying hard enough, we really are approaching this in the wrong way, and we are going to make it very hard for them to succeed if we come about it from a willpower stance. So finally, I really think it's important to think about what matters most to the patient. what is it that they want? What are their goals? What's their health, their function, their own, central goals for the reason in which they're looking to potentially change their weight or improve their health from that standpoint. So this is especially true for our older adults. Again, for a lot of my patients, the goal isn't, I want to get down to a certain weight or a certain size. It's really, I want to stay independent, right? That's the power of working with our older adults, is they really oftentimes are speaking about that importance of independence. So at the end of the day, I think these are extremely key things that we can start with, really paying attention to the whole person, and understanding that what matters most to the patient should be first and foremost, and really being able to use that patient first language.
Great, thank you. We've heard about definitely patient first from Doctors Batsis and Starr both. We also heard Dr. Starr say treatment options, and I'm pleased to say for our older adults, we have a few more options right now. And so, Christy, I'd like to turn to you and talk about new Medicare payment policies. We've got some changing access to obesity management medications. Could you provide our viewers with an overview of the policy changes?
Sure. And thank you, Jen, and everyone for participating in this webinar. I'm thrilled to be here and talk about what we all now know is the Medicare Bridge program. But just to back up a little bit, part of these are, both John and Katie had great points about how to work with patients who are living with the disease of obesity and are looking for treatment, but they've really been handicapped in what they've been able to provide under the Medicare guidelines, because there is a prohibition in Medicare under Part D for providing or covering obesity medications. And so we think of those now as the GLP-1 medications. And that is exactly what this new demonstration from the Center for Medicaid and Medicare Services under the Department of Health and Human Services is now doing. It's called a demonstration project because it's temporary, but it is allowing providers to prescribe GLP-1s to people that are on Medicare for the first time ever. And the program started July 1st. It'll run through the end of 2027. And we're working on options for ways to continue that beyond that. Would you like me to go into a little bit of the details about the Bridge program?
Yep,
great.
That would be great. What should patients and providers know about really opportunities and limitations?
Sure. So first of all, a person is eligible if they do have a Part D plan, although this program runs separate from the Part D plan, but that is sort of the first thing that they will look at is whether you have a Part D plan. And then you have to be at least 18 years and older. There are 3 different categories under the BMI category for where you might fall and able to get a prescription. So if you have a BMI of 35 and above, you are eligible. If you have a BMI of 30 to 35, it's really dependent on other comorbidities that you might have. And there's a list of those in both on the website and on our website at OCAN. And then again, for 27 to 30, if you have pre-diabetes, then you also will qualify for the Bridge program. There's 3 medications that are covered under the Bridge program. These are medications that are currently on the market. So for the Wegovy, it is the Wegovy pen, as well as it's all Wegovy pens, sorry, as well as the new Wegovy pill. There's also a pill called Foundayo, which is a new product, fairly new product that also is covered. And then the product Zepbound Quick Pen is the only one that is covered. So basically the process is that a patient would go in and to see their provider, like John or Katie or others, have that conversation with the provider. And if they're interested in starting medications, or if they've already been on medications and they'd like to see if they qualify under the bridge program. There's a checklist that the provider would go through, but really they would, it's as simple as sending the prescription to whatever pharmacy the patient would like to use. So there's no pharmacy that they have to send it to. It's helpful if the provider writes some things on that prescription, such as send to the bridge program so that the pharmacists know where to send it to. It's also helpful to have the diagnosis code, the E66 code on there for the pharmacy to see that. And then the pharmacist really plays a pretty big role in this program, in the sense that the pharmacist needs to take that prescription, send it to the central processor, who will look at the prescription and see if the patient does have a Part D plan and if they are eligible. They'll then ask the provider to send a prior authorization form. It's a simple form. You can actually find it and download it right off of the CMS website. And then you complete the prior authorization, send it back, and they say that they are turning those around fairly quickly on whether the prescription can be filled. And then it's up to the pharmacy to then let the patient know that they've gotten the prior authorization has been completed, they fill the prescription, and they come pick up their prescription. The patient's role in all of this is to really have that conversation with their provider to, make sure that the pharmacy, if there are any glitches, knows that this is supposed to be going to the bridge program. And then they pay $50 a month for their prescription. And that is above any type of copay or coinsurance that they might have to pay through Part D. So this is a completely separate program.
Okay, great. And then I'm interested in, you mentioned a little bit about prior authorization, about documentation, about billing codes, but I'm wondering if there's any tips or tricks that you haven't mentioned that you think would be useful. But I'm also curious because you mentioned a couple of things I'd like to follow up on. You have those BMI thresholds, but then you also alluded to someone previously already being on GLP-1. So do they have to be on those thresholds at the first time they fill that prescription in Bridge, or can that have been at the beginning of their experiences with GLP-1s?
That's a great question, Jen, and it's something that has definitely come up a couple different times. So if they started a GLP-1, however they started it prior to the Bridge program, and they are interested in sort of carrying this over into the Bridge program, the provider should use the BMI threshold and the comorbidities that the patient had prior to starting the GLP-1. So, for example, if they have lost some weight along the way and their BMI has changed, the provider should on the prior authorization, they should use the BMI that they were when they started the medication. So that's one question to that, or one answer to that question. The other is that if the patient has some of the conditions that should be covered under Part D for the use of a GLP-1, such as diabetes, moderate to severe sleep apnea, and MASH, which is a liver function disease, if they should actually be getting their prescriptions through the Part D plan. I know this is a little bit frustrating because in many cases, people have tried to get their prescriptions filled through that Part D plan and have run into barriers. There are some Part D plans that are covering those medications, but at a very high copay for the patient, the beneficiary. But we are going to be working on that as well, because we know that, through putting this program together and working with CMS, we've really been hearing from patients that, a $50 copay would be much better for them if they could fall under the Bridge program. A couple other questions that have come up that I've seen have been about sleep apnea. So if someone has mild sleep apnea and that's in their chart, then they should be able to qualify under the bridge program. It's the moderate to severe sleep apnea, and if that's how they are supposed to be getting the GLP-1, that would need to go under their Part D plan.
Okay, great. Thank you. So, Dr. Batsis, as we begin to have access to these medications, why is it especially important for older adults to pair other weight loss strategies that preserve lean body mass, strength, mobility, and independence along with those highly effective medications?
Well, that's a great question, Jen, and one that I love entertaining when I'm prescribing these medications to my patients. We need to think about this. We, meaning the health system, healthcare providers, need to think about this, but the treatment of obesity as being multifactorial, multifaceted. And I think that's been alluded to by some of the others on the call. So it's not just here's the medication, here's the prescription, and off you go. I'll see you back. I'll see you as a patient back in 3 to 6 months. That's actually really the wrong philosophy. My opinion, others' opinions, and the like. And here's why: is that when one loses weight, one loses fat, muscle, bone, and some other tissues. But let's focus on the loss of fat, loss of muscle, and loss of bone. That we know. We know that from lifestyle-based studies that you lose those three compartments. Loss of fat actually is what we're trying to achieve because we know that is metabolically active, that leads to higher degrees of inflammation, leads to a variety of different other comorbidities and medical conditions. So we're trying to minimize, we're trying to maximize, sorry, the loss of fat. However, we know that even with intentional weight loss through lifestyle measures, you will lose some muscle. And again, depending on how you measure it, I'm not going to get into that, the details of that today, but loss of muscle is a metabolically active organ. So what we really need to do is preserve or mitigate the loss of muscle mass. And we've seen that. We've seen that resistant exercises and predominantly coupled with aerobic, coupled with nutritional strategies, and this has been seen extensively in lifestyle-based studies, you can lose a degree of muscle. That said, you may improve function. Just loss of muscle is not the be all and end all. You want to be able to preserve function at the end of it. And I think we need to move away from the paradigm that loss of muscle is bad. You may lose muscle, but where you're losing the fat is really where it's important. And often in patients with obesity, there's fat embedded within the muscle. That intramuscular fat is what we term. That is bad fat. That's called ectopic fat. That is highly active and it leads to a negative vicious circle. So using resistant exercise, aerobic exercise activities, strength training, using bands, using weights, augmenting, working collaboratively. This is, again, the key term. I've mentioned this, Katie mentioned this, and the like. We need to work collaboratively. It's not only a clinician or provider, it is the team. So working with a physical therapist, exercise specialist, and working with a registered dietitian nutritionist, increasing one's protein throughout the day, increasing one's exercises. This can help mitigate that loss of muscle mass and improve physical function, which is what we're trying to achieve.
Great. Well, you mentioned specialist in exercise, so let's turn to Paige now because we have one of those here. Paige, where does exercise fit in as a foundational treatment for older adults with obesity, regardless of whether or not they're using a medication to support their weight loss?
Well, first of all, thanks so much for having me join this incredible group to talk about this very important topic. It's great to be here with GSA. Exercise is not an add-on to obesity care for older adults. It really is one of the foundations of good care. And I think we've we've heard that here already today, but I'll emphasize it as well. Weight loss can improve cardiometabolic health, certainly. But for older adults, what we've heard over these many years is that what matters most is whether they can keep doing the things that allow them to live independently. So, walking safely, climbing stairs, getting out of a chair, carrying groceries, and participating in family and community life. So that's why exercise really does need to be integrated from the beginning, whether someone is losing weight through lifestyle treatment or medication or another approach. Exercise, as others have said, really supports strength and mobility and balance, endurance, confidence, that quality of life that matters to folks. Obesity treatment should not only be defined by pounds lost, but better health and better function, and the ability to remain active and independent.
And so Dr. Batts has talked a little bit about the role of resistance or about resistance training, but tell us about what the evidence says about the role of resistance training, strength training to really help older adults lose fat while maintaining that function and muscle strength.
Well, the evidence is very consistent on this point. It really is that resistance training is essential during weight loss in later life. When older adults lose weight, they can lose some lean muscle mass along with fat. So strength training helps counter that by preserving muscle mass, but also improving strength and supporting the physical abilities that support what we do in daily life. I think Dr. Batsis did this very well already, but I'm going to reiterate that it's people have a picture in their head about what strength training is. And it's many things, right? It's bands. Yes, it can be heavyweight equipment, but it's bands, it's body weight, it's chair stands, it's group exercise classes, it's light weights, it's machines. It can be all of these different things. It's things you can do in your home. It's not necessarily big weight plates and squats only. So I think there's a literacy that we need to work on around resistance training and what it is for folks. But the goal really is, safely progressing strength in the major muscle groups. And you can do that in all those different ways that I just listed. For older adults with obesity, the message really is that we're not just trying to lose weight, we're trying to lose fat while protecting our strength and our mobility and our resilience.
Great. Resilience is a great word as we're talking about older adults and certainly the group folks that care for them and care with them. Paige, we often hear about time as a major barrier to everything in clinical care, whether it's medicine, whether it's nutrition, whether it's PT, whatever it is, we're looking at time. And so a busy clinician may just have a few minutes with a patient. So what are the most important evidence-based recommendations that they should give to older adults in those few minutes? And what are essential components of an effective program that that clinicians should be communicating with older adults?
Yeah, it's such a great point. And I think it's very important that the recommendation be simple and actionable, and that we all need to recognize this is not a one-time conversation, right? So we have many opportunities to add on to it. I think first we need to encourage patients to move more and to reduce long periods of sitting. I mean, that's a great start for folks. Second, aiming towards that regular aerobic activity, such as walking or water exercise, cycling, something that gets the heart rate up, that is sustainable, something they enjoy. That's always going to be something that folks will do more of, right? But there's also that real reality that some folks don't enjoy anything as far as movement goes yet. So, just doing something where we get our heart rate up and keep it up for a little bit. Third would be including those muscle strengthening activities at least twice a week. And then fourth would be adding balance training. And I would say that's particularly true for anybody that has a history of falls or fear of falling or mobility concerns. That's really, really important. As far as what the essential components are, they're going to be that, aerobic activity and the strength training, the balance work, flexibility, or mobility is needed with that gradual progression, right? So not doing it all at once. I think the most important clinical question is not really what's the perfect exercise prescription. It's what's the next safe, realistic step for the person I'm talking to today, you know? So for many older adults, that may mean starting with, 5 or 10 minutes using a chair for support, or joining a class or choosing a low impact activity that doesn't worsen pain, and it's small steps.
Great, thank you. Could you give a couple of examples of more low impact? You mentioned using a chair, and what are some examples of low impact kind of strengthening exercises that older adults might do at home?
Yeah, I think when we think low impact, a lot of times with the low impact, we're talking more about the cardiovascular work. And we want to have at least 1 foot on the floor is how we've always thought of lower impacts. So we're not talking about jumping jacks or, box jumps or something, right? We're talking about moving. Walking is a great one. Walking's a great way to get started, but it's not for everyone. So, we can certainly do marching movements in our chair, but we don't want to do too many of them because we're seated and we'll overuse parts of our legs and feel sore. So again, it's the small movements that we start with. Those sit to stand movements are very practical, and you can certainly start with a chair or a walker with the wheels locked in front of you, to provide some support, or a counter to stand up and sit down. But this is very practical, right? It helps us with daily activities that we do every day. So I always think sit to stands are a great one, certainly, and walking are great to start with.
Great, thank you. Well, Dr. Batsis, what about ongoing monitoring? So for clinicians who are using the CARE Toolkit, and they're monitoring that older adult once they begin obesity medication, particularly around nutrition, muscle loss, functional status, and medication tolerance. So what are really some key points around monitoring as someone begins medication and then continues on that journey?
And before I jump into that question, Jen, I just want to just echo Paige's shared. You know, the big picture here is that we need to individualize this to the patient. And not everybody. There are going to be some individual patients who are unbelievably physically active, and this goes back to the point of this is not a willpower issue. This is a biology issue that Katie shared to the audience earlier on. So we really need it. It's not a one size fits all approach. We need to individualize. We need personalized approaches. So we have it in our toolkit of what can be used, but then we need to adapt it to each individual patient. Now, to your point here in terms of ongoing monitoring, I'd love to say that I wish we had a robust amount of evidence here, but we don't. And particularly evidence where we have clinical trial evidence of what we probably should do versus what can actually be done in clinical care and reimbursed. Often two different things. So let's talk about, the multidisciplinary team. We know we have intensive behavioral therapy that could be covered. However, for treatment of obesity, treatment using registered dietitians, you have to have a diagnosis of diabetes or chronic kidney disease to get medical nutrition therapy. And I see Katie smiling there. So there are things from a policy standpoint that we need to get changed for us to have this comprehensive care. When I think about how do I approach from a medication management, I think that's where your question was heading as well, is it's a start low, go slow kind of paradigm. Just like anything in geriatric medicine, we need to take things one step at a time. Yes, there may be a package insert that says titrated up to this degree. We know that there are actually some evidence from retrospective studies in clinics that have modestly ramped up that there may be better tolerability. One of the major adverse events and adverse side effects in patients initiating these medications are gastrointestinal. We know that slower ramp up may reduce the GI side effects that occur. So bringing the patient back more in a more timely manner, maybe not, at a 3 or 6 month, maybe I bring them back, have a phone call. And I think what was mentioned earlier, pharmacist driven kind of protocols where pharmacists can kind of check in with a patient. We have that in one of our practices here where they check in on a regular basis, have them come in and see the clinician, their clinical provider, the prescriber, a 2 months period of time. So slow ramp up, then see where they are. Again, it's not about the weight, it's about tolerability and it's about how they feel. And then we can potentially ramp the dose up at that point. In addition, we should be monitoring their physical function. And when we think about sarcopenia, the loss of muscle mass and strength with aging, you can get secondary sarcopenia as a result of weight loss. We see that very much so in unintentional weight loss, but it can be seen as well in at-risk patients with who are intentionally losing weight. Here's the challenge. Measurement of body composition is not routine or par for the course. No one reimburses for that. There are some subspecialty clinics that may do that or may charge patients for that. So how do you circumvent that? Because you don't have that muscle mass component. But you can assess muscle strength very easily. A dynamometer, it's a handheld kind of apparatus that can be done very easily by your support staff. Takes minutes, if that. If you don't have the capabilities for that, have them do a timed up and go, sit to stand test. Very easily done in a practice with, the technology you need a chair and maybe a stopwatch at this stage. So that's something else. So that's from a functional standpoint, from a bone standpoint. Ideally, measuring bone mineral density, we know that intentional weight loss can lead to loss of bone mineral density. That's usually over a longer period of time. But in patients that may be eligible, there are a significant number of Medicare eligibility criteria to conduct bone mineral density scans. You don't need to do it at frequent intervals. You do it at baseline, maybe before you start, and maybe at 2 years or at a year. But you need to be creative in terms of those monitoring strategies. Those are just kind of some of a high level.
Okay, great. Dr. Starr, it's exciting on this call to have an interprofessional team. So how do interprofessional teams, primary care, or geriatrics, or nutrition, pharmacy, rehab, community partners, everybody who's involved in the care of that older adult, coordinate care so so older adults do receive that support beyond the prescription itself?
Yeah, absolutely. And I'll be echoing a number of things that all the panelists have mentioned. Right? We think about the prescription as it's a starting point. It is not the whole treatment plan. And I think that is extremely, extremely important. We oftentimes see patients being prescribed these medications without any other interprofessional team members alongside them. And so we really have to start thinking about, as we have said multiple times, obesity is multifaceted. And because of that, we really have to have an interprofessional team when we are using these medications and across the weight loss journey regardless, but especially when we are using these medications. We think about our primary care, our geriatricians, they're the ones that are going to hold those long-term relationships. They're managing the other conditions, they're reviewing the medications, they're helping set those goals, really thinking about what matters most and keeping an eye on the side effects and those GI issues that somebody might be experiencing. So again, bringing these individuals back, thinking about the functional status and those change in function and that change in function over time. We have our dietitians. We know that these medications suppress appetite. Our dietitians are essential to being a part of this team. They can really help make sure that our older adults, particularly, are getting in enough protein. We're really generally shooting for 1 to 1.2 grams per kilogram of body weight, if not even a little bit more, during that active weight loss. One of the other concerns that we have are micronutrient deficiencies, right? Again, with that appetite suppression, with potentially having very low calorie diets because of that appetite suppression, we can see micronutrient deficiencies. So again, even checking those and making sure that individuals are getting in adequate calcium, vitamin D, and our other micronutrients is essential. We also know that when we combine nutritional support with these medications, we actually see a reduction in some of those adverse GI effects. And a lot of that has to do with the counseling of how to integrate nutrition throughout the day. And again, making sure that they are getting in that adequate protein. Our pharmacists really have to carry a quite a bit of load here, right? We know our older adults are typically taking multiple medications. And so being able to help with the titration, the tolerability, all of the interactions that could be going on, all of those are really, really important. And we need to be able to communicate that back to the team members. Dealing with the access and prior authorization, I think, is one of the other things that is a challenge. And again, I'm so glad we have Christy on here talking about that, because we know that that is a very big barrier. From a rehabilitation standpoint, love our physical therapist, our occupational therapist, our exercise physiologists, really thinking about that structured exercise. Paige did such a wonderful job really talking about that resistance training piece, how we are thinking about protecting that muscle, especially when we have individuals who could potentially be losing a substantial amount of weight. Again, as John said, it's muscle, it's fat, it's muscle. And over a longer period of time, it can be bone. So we really want to be thinking about how we can protect the strength and the function of our older adults. Again, tying that back to that independence piece. Like, this is really, I think, the single biggest safety concerns that we have for this population is putting them on these medications and potentially having them lose their independence. And then our community partners, again, thinking about programs like Enhanced Fitness, Move On, Gerofit, Vivo. All of these are going to extend past that clinical wall. Again, this kind of goes back to our KAER Toolkit and that refer piece. They are going to help keep our individuals moving. They're going to help with that social connection. We know the importance of the behavior change, and having that accountability plays such a big role in that journey of making these behavior changes. And these community partners are just an essential piece to that interprofessional care. I think the biggest challenge we have is how we communicate this care between each other. Again, I think understanding how to have warm handoffs, closing the loops, shared decision-making, shared goals, clear ownership. And then also, I will have to say, being able to educate our patients on having to be advocates for themselves, because a lot of these systems don't talk to each other. And if we can help our patients actually be advocates and be able to communicate, I think that also adds a whole nother layer in there of that interprofessional care. And again, that patient is at the center of that spoken hub of that care that we want to be able to provide. So I love our interprofessional teams, and I am optimistic about the opportunities that the future holds for our ability to work more as an interprofessional team and provide interprofessional care, particularly around the disease of obesity in our older adults.
Right, thank you. Paige, earlier you alluded to a couple of barriers that older adults face, like fear of falling or lack of confidence, but they also may have limited transportation, or just lack safe places in their neighborhood, or have pain that may limit them from exercising. what signs might tell an interprofessional team member that a patient may actually benefit from a referral to a structured evidence-based community program rather than trying to go it alone?
Yeah, that's a great question. And I think referral is such an opportunity, which is, I think, what I just heard from Katie Starr. Uh, I think about referral when the barrier isn't just knowledge, right? It's like they know that they should be more active. I think a lot of times that's unknown, but the patient needs more support. They need structure, and kind of this system to provide a safe environment to, improve. So referrals especially important when, as I said before, with the fear of falling, or if there's pain that limits activity. Significant deconditioning, I think, would be another instance where, for instance, physical therapy can really be a huge boost. Low confidence, social isolation, transportation challenges, a lot of those are solved with our community partners, and they have very good systems in place. A structured program can provide instruction, it can provide progression, it can provide accountability, and it really does provide a lot of social connection to not only the exercise component, but additional resources. A congregate meal that's been reviewed by a dietitian, right? Like all of these other things are in place as well. I think for clinicians, keeping an ear out for cues such as, I'm afraid I'll get hurt, or I'm concerned about the cost of this. A lot of the evidence-based community programs like, Enhanced Fitness or GeroFit or some of the Fit and Strong, some of the others mentioned are low cost. Sometimes they're free depending on the center that's providing them and their funding sources. I don't know what's safe. I can't stay motivated, or I don't have anywhere to go. Well, so maybe, Vivo or another program's a great fit for them. And these become almost like, I know it sounds a little corny, but it becomes kind of this fitness family when a lot of your other friendships and other support have dropped away, through the years. And they provide this great incentive to not only go to the exercise class, but the next thing you know, you're doing an additional walk, meeting these folks, on an additional day. And it just sort of can grow from there. So these are the kind of signs that I think a community-based exercise program may be a good fit. And it may not be from the primary care office directly. It may be primary care to physical therapy and then to a community-based program, right? So again, that interdisciplinary team is key.
Well, Christy, I'm going to give you one more question before we take a couple of from the audience, and I see that Dr. Batzes has answered some in the Q&A box itself. Thanks so much for doing that. So, Christy, we've talked about the Bridge program, but we also have the potential for the balance model to begin in 2028, which would really be an additional, potentially lengthier demonstration. So these are positive steps forward for access, but are they enough from a policy standpoint? What's needed for older adults to truly have access to comprehensive obesity care that we've discussed here today?
Well, what we really need is for the federal government and CMS to take a look again at the rule here and determine that these are not weight loss medications, but these are medications for the treatment of obesity. And we would argue that by determining that obesity is a disease and these are medications for the treatment of obesity, that would allow them to be able to cover these medications, and not just GLP-1s, but some of the older medications, as well as any new medications that are going to be on the market in the next several years, under the Part D plan, and we believe that that would make things, a lot more accessible, as well as sort of level the playing field for everyone to be able to have access to these medications. There's one other way, which is legislation that has been introduced every Congress for about a decade now, called the Treat and Reduce Obesity Act, which would not only change the law and allow medications that are for weight loss to be covered under Part D, but it would also improve the intensive behavioral therapy program that is under Medicare, so that a lot more providers like probably Dr. Starr would be able to get reimbursed for doing some of that intensive behavioral therapy work that is right now only covered if you're a primary care physician or in a primary care setting. And so that is important legislation that we will also be looking at potentially being reintroduced next Congress as well. But right now, I think what we're really anxious about and excited for is getting some of the data out of the Bridge program to help policymakers, members of Congress, those at the Department of Health and Human Services, to really make these decisions about, sort of how important this program is, what we can see from covering obesity medications for people on Medicare, and really continue this program, whether it's through the Bridge, extension in the Bridge program, through the Balance program, or through some other vehicle like a proposed rule from the administration or legislation that's passed. So we've got a lot of different avenues. I saw there one question was asked, what should we say to a person who wants to go and start a medication under the Bridge program that is concerned about the program ending? I really would say I'm very hopeful that we are at the precipice of change here. We just need to figure out what the vehicle is going to be. It's kind of like at that stop road, you go, left, right, or center. But I really think something is going to happen. And if you're really interested, we'd love to have you advocate with us. And we really appreciate all the advocacy that GSA and your members do.
Thank you. Thank you for answering that question too. That leaves us one Q&A, and we've got 2 minutes to answer it. And Dr. Batsis has indicated he'd like to answer this live. The question is, given the critical importance of maintaining strength and function in older adults, please discuss treatment considerations, e.g. GLP-1s, specifically for patients diagnosed with sarcopenic obesity and risks associated with GLP-1 use in the at-risk population.
I'll try to make this short because this is a huge topic and we can kind of talk for a while on this. Here's the challenge. It's really about understanding and identifying these at-risk patients with sarcopenic obesity. And as I shared, one of the challenges is really identifying them in clinical practice. Well, there are algorithms for this. And again, done predominantly in subspecialty clinics. The Sarcopenic Obesity Global Leadership Initiative has come up with a clinical algorithm for screening, diagnosing, and staging sarcopenic obesity. Once you determine someone may be at risk or may have sarcopenic obesity, then it's really, again, come back full circle. Start low, go slow, really careful monitoring thereof of body composition, physical function, and quality of life. We don't have robust evidence in this population at this time. There's no doubt there's going to be individuals who will benefit from these medications. There are going to be individuals that will not benefit from these medications. And we're going to have to look at biology at some point and looking at biomarkers as to who will be those who respond favorably and those who will be unable to respond. So I wish I had a better answer for you. A lot of this is clinical acumen at this stage.
Great. Thank you. And it's 1 minute till 1 o'clock. So I just want to say, now it's 1 o'clock. Thank you so much to our panelists. I so appreciate, one, your passion for the work that you do, your commitment to improving care for older adults, and so much for your participation in this panel today. And I'd like to thank all of those folks who joined us, and we hope you found this informative and enjoyable. And again, my colleagues on the screen with me, thank you so very much. Take care, everyone.